Welcome back. In this lesson, we begin step 2 of the diagnostic pathway for transthyretin cardiac amyloidosis, focusing on monoclonal protein testing and nuclear imaging. Following the identification of clinical red flags in step 1, step 2 marks the point where diagnostic strategies begin to diverge across major clinical guidelines. The European Society of Cardiology, ESC, recommends a dual-pronged approach, performing monoclonal protein screening alongside bone scintigraphy with technetium-labeled radiotracers such as 99-MTC-PYP or 99-MTC-DPD. This concurrent method enables both sensitive detection and early differentiation between AL and ATTR amyloidosis. Excluding AL amyloidosis. Before confirming a diagnosis of transthyretin cardiac amyloidosis, it is essential to exclude AL amyloidosis through monoclonal protein testing. This step is critical, as the treatment approach and urgency differ significantly between the two forms. 3 core laboratory tests are used in combination to ensure accurate detection: serum free light chain (FLC) assay, immunofixation electrophoresis (IFE), and serum and urine protein electrophoresis (SPEP and UPEP). This triple testing strategy is highly sensitive, detecting nearly all cases of AL amyloidosis when performed together. Importantly, a completely negative monoclonal screen is required before advancing to nuclear imaging to confirm ATTR-CM. It is crucial to note, electrophoresis must always be performed with immunofixation to maximize diagnostic yield. Omitting immunofixation significantly reduces the sensitivity of these assays. Failing to rule out AL amyloidosis before proceeding could lead to misdiagnosis and delayed treatment, particularly since AL amyloidosis requires urgent intervention with chemotherapy or targeted therapy. Let's now walk through these 3 key diagnostic tests. 1. SPIE serum protein electrophoresis with immunofixation. What it detects: clonal immunoglobulins or clonal light chains. Primary diagnostic value, confirming monoclonal immunoglobulin production. Normal result, no monoclonal protein present. Limitations. Both serum protein electrophoresis and immunofixation must be performed. Not all labs do this by default. Up to 30% of patients with AL amyloidosis may have false negative results. 2. UPIE urine protein electrophoresis with immunofixation. What it detects also targets clonal immunoglobulins or light chains. Best for confirming monoclonal light chain production in the urine. Normal finding, no monoclonal protein present. Limitations. Light chain excess can be either monoclonal or polyclonal, making interpretation tricky. Mild abnormalities should be interpreted with caution, especially in patients with kidney disease or systemic inflammation. 3. SFLC serum free light chain assay. What it measures: the ratio of kappa to lambda light chains in the serum. Diagnostic utility: detects low-level clonal light chain production and helps identify subtle cases of clonality. Reference ranges: free light assay 0.26 to 1.65, N-latex assay 0.53 to 1.51. Limitations: often not positive on its own and best interpreted in combination with other tests. Sample collection is somewhat cumbersome. Special consideration in kidney disease. In patients with impaired kidney function, mild elevations in the kappa to lambda ratio are common, even without true amyloidosis. For example, in those with an eGFR of 45 or lower, a ratio as high as 2.0 or 3.1 in patients on dialysis can still be considered within the normal range if other results are negative. This correction, however, does not apply to the N-latex assay. If any of these tests show abnormal results, bone scintigraphy alone cannot confirm ATTR amyloidosis. In those cases, histological confirmation, typically via biopsy, is required. In the absence of a detectable monoclonal protein and a normal serum-free light chain ratio, the specificity of grade 2 or grade 3 cardiac uptake on bone scintigraphy for ATTR amyloidosis is considered to be nearly 100% when the disease is clinically suspected. In other words, if the monoclonal screen is negative, a positive scan at grade 2 or 3 is highly reliable for diagnosing ATTR-CM. However, there's an important caveat. Scintigraphy should always be performed with single photon emission computed tomography, or SPECT. This is necessary to verify that the radiotracer uptake is localized to the myocardium and not simply pooled in the cardiac chambers, which could lead to a false positive. Even with SPECT, rare conditions can mimic cardiac uptake and produce misleading results. That's why awareness of potential false positives and false negatives is critical during interpretation. Let's take a closer look at these scenarios summarized in Table 2. False positives can occur under several conditions. AL amyloidosis. If any of the monoclonal screening tests, SPIE, UPIE, or serum-free light chain ratio, are abnormal, bone scintigraphy cannot be used as a standalone diagnostic tool. Histologic confirmation is required. Hydroxychloroquine cardiac toxicity, considered if the patient has a history of hydroxychloroquine use. Diagnosis also requires biopsy. ApoAI and ApoAII amyloidosis. These often occur alongside kidney disease and may require genetic testing for confirmation. ApoAII amyloidosis, also associated with renal dysfunction. Again, histologic analysis is necessary. A beta-2M amyloidosis, typically found in patients on long-term dialysis, usually over 9 years. This too requires histologic confirmation. Blood pool artifacts. In cases of cardiac dysfunction, radiotracer may remain in the chambers rather than binding to the myocardium. SPECT helps differentiate this by confirming true myocardial uptake, and delaying acquisition can improve accuracy. Rib fractures or valvular and annular calcifications. These may show uptake that mimics myocardial binding. SPECT is used to distinguish this from true cardiac involvement. Recent myocardial infarction within the last 4 weeks. Inflammatory changes can cause diffuse uptake. Again, careful timing and use of SPECT are key for accurate interpretation. Now let's shift to false negatives, cases where ATTR-CM may be present, but scintigraphy appears normal. Certain hereditary ATTR variants, such as Fe84 LOI or SIR97TIR, may not produce significant tracer uptake. These are often linked to neuropathy or a strong family history. Genetic testing is essential in such cases. Very mild disease. In early stages, the amount of amyloid in the myocardium may be insufficient to show on imaging. Biopsy remains the gold standard for confirmation. Delayed or premature acquisition, timing matters. If images are taken too early or too late, uptake may be missed or underestimated. Adjusting the acquisition window can improve detection sensitivity. To summarize, while bone scintigraphy is a powerful and highly specific tool for diagnosing ATTR-CM, especially in the absence of monoclonal proteins, it is not infallible. Proper test selection, use of SPECT, and awareness of false positives and negatives are critical to ensuring diagnostic accuracy. Now, let's turn our attention to a real-world case that illustrates why monoclonal protein testing must never be bypassed, even when clinical and imaging findings strongly point toward transthyretin cardiac amyloidosis. Hello, Dr. Mary.
Hello, Amanda. Actually, today's case brings to light one of the rare but diagnostically challenging scenarios: coexisting AL and A TTR cardiac amyloidosis. Let's begin with the patient profile. We're looking at an 83-year-old African-American male with a complex medical history: hypertension, severe aortic stenosis treated with transcatheter aortic valve replacement, lumbar spinal stenosis, and bilateral carpal tunnel syndrome. He presented with exertional shortness of breath and signs of volume overload, which prompted further evaluation. On electrocardiography, there was atrial fibrillation with low-voltage QRS complexes, both classic red flags for infiltrative cardiomyopathy. Echocardiographic findings showed concentric left ventricular hypertrophy, preserved ejection fraction of 60 to 65%, biatrial enlargement, and diastolic dysfunction, a constellation of features highly suspicious for cardiac amyloidosis. At this point, based purely on imaging and presentation, many clinicians might suspect ATTR-CM. But here's where the case takes a critical turn, through the lens of monoclonal protein testing. Laboratory analysis revealed a serum-free light chain assay with a kappa to lambda ratio of 113, indicating clear overproduction of a clonal light chain. This result immediately raised the suspicion of AL amyloidosis. Further confirmation came through serum and urine immunofixation electrophoresis, which were positive for monoclonal IgG-kappa. A bone marrow biopsy was then performed, revealing clonal plasma cell proliferation consistent with multiple myeloma. Adding to the clinical picture, cardiac biomarkers including troponin and NT-proBNP were modestly elevated, strengthening the concern for myocardial infiltration. Now here's the critical step. To conclusively determine the type of amyloid involved, the patient underwent an endomyocardial biopsy. And what that biopsy revealed was extraordinary: dual amyloid deposition. Mass spectrometry identified both light chain amyloid and wild-type transthyretin amyloid within the myocardium, a rare but clinically significant finding. Let's look at the biopsy results that led to this diagnosis. Figure C displays a histologic section of myocardial tissue stained with hematoxylin and eosin, H&E, at 10x magnification. Notice the pale, amorphous deposits interspersed between myocytes. These are classic for amyloid infiltration, reflecting displacement of normal myocardial architecture by amyloid fibrils. Then in Figure D, the same tissue sample is viewed under polarized light after Congo red staining at 20x magnification. Here we observe the characteristic apple-green birefringence, confirming the presence of amyloid deposits. This optical signature is pathognomonic for amyloidosis and remains a cornerstone of histologic diagnosis. Together, these findings confirm not just the presence of amyloid in the myocardium, but they also underscore the critical role of biopsy and tissue characterization, especially when imaging and laboratory tests reveal overlapping features or suggest the possibility of dual pathology.
Thanks, Dr. Mary. This case powerfully illustrates why monoclonal protein testing should always be performed before relying on nuclear imaging to diagnose ATTR-CM. Even if technetium-labeled scintigraphy had shown high-grade uptake, it could not have distinguished between ATTR and AL amyloid deposits. Had the diagnostic workup stopped at imaging, the patient might have received the wrong treatment, potentially delaying life-saving chemotherapy for AL amyloidosis. So what can we learn? First, never skip monoclonal protein screening in patients with suspected cardiac amyloidosis. The tests, serum FLC assay, SPIE, and UPIE, are non-invasive, relatively inexpensive, and provide essential information to guide further steps. Second, even advanced imaging is not infallible. When there is any suspicion of dual pathology, particularly in older patients with red flag findings like low voltage on ECG or preserved EF, despite thickened myocardium, biopsy and tissue typing are warranted. And finally, this case reminds us that treatment decisions hinge on precise diagnosis. AL and ATTR amyloidosis have vastly different therapeutic approaches, prognoses, and follow-up strategies. Missing an AL component, especially in the context of a plasma cell dyscrasia like multiple myeloma, can be fatal. In conclusion, this case study doesn't just underscore the role of monoclonal protein testing, it makes it clear. You cannot diagnose ATTR-CM without first excluding AL amyloidosis. This is not just a protocol, it's a principle of safe, effective, and evidence-based care. Stay with us as we explore the role of bone scintigraphy and its proper use in the diagnostic algorithm for ATTR-CM in the upcoming lesson.